Welcome to What the Health? The podcast where anything health is fair game. There's a lot of garbage advice and misinformation out there that can leave you feeling stumped and stuck. Together, let's sift through the sea of BS and find the best ways to get healthy and stay healthy. Join the team as we tackle the trends and bust the myths about health and wellness. Here are your hosts, Dr. Dan Turo, Angela Turo, and Dr. Riley Brown.
Welcome back, everyone. I have the honor of introducing Dr. Anna Owen, who just opened up Keystone Physicians Direct Primary Care. See, I did it right. I was so concerned I was going to forget.
It's long.
We will have all website and information in the comment links, and we'll hopefully all the great technology now we get to put it up across the bottom. I'm sure it's there. But Dr. Anna and I originally found someone posted on one of the community groups, and they posted, you were like, hey, this doctor just opened up, and I saw direct primary care, and I have so many patients that ask me all the time, who do you refer to for a primary care doctor? Because they're looking or they're upset with, their current doctor or, a situation that happened. And so I get so many questions all the time, and I never, there's a couple in the area that I've, gotten to know, but it's like, I never had. So immediately when I saw you were opening up in, Bellevue, Avalon, then I checked out your website. I went to the website. I'm like, I fell in love. I was like, yes, you're speaking our language, and we're going to get into talking about that.
Yes.
And then we actually met at a referral networking group.
Yep, it's Kismet.
Yes. So I sat down, and I didn't introduce myself right away because, it's typical, a lot of people going on, I'm talking left, right, but I recognized you were a guest. And so finally, I think you reached over to me to introduce yourself. I'm like, wait, Dr. Anna, you're Keystone Physicians. I'm like, I wanted to talk to you. And you're like, I wanted to talk to you. So here we are several months later now. And I just wanted the opportunity to share Dr. Anna's story. Because I think philosophically we agree on so much. And I really think that our vision, we share a very common vision for the future of healthcare in the United States, and how that can be, how that can really be emphasized from a grassroots perspective on a local level. So global vision with a local mission, right?
Yes.
So I want to take the opportunity, with this discussion, just to get to know you a little bit more, and hopefully have the opportunity for, patients and potential patients to get to know you and hopefully find their way to the amazing care that you provide. So welcome.
Wonderful. Thank you for having me. I'm very excited to be here. And yeah, it was absolutely perfect that we met. I had been wanting to meet you because I heard all the reviews, and people had told me by word of mouth that this was an amazing chiropractic clinic, and this is a place I needed to come to and meet, especially you, and also Erin.
Yes.
And
she's the boss.
She's the boss. And everyone's like, you got to meet the duo. They're magic. And then it was just perfect because I hadn't quite called you yet, and then we met up.
Yes. So talk to me. So then I did come down and see your facility, which is absolutely beautiful, and I love it. But before we get into that, let's talk about why medicine. What made you want to become a doctor? Let's rewind, go back, because usually there's a time in someone's life, or maybe not a specific event, but a series of events that happen. So why, what was it that made you decide you wanted to become a medical doctor?
Yeah, it was not on my menu of options. Growing up, I wasn't a little kid with the stethoscope and the reflex hammer playing doctor and pretending that that's what I wanted to do. It was not even on my radar until later into high school. And then as, bodies are developing in high school and information at that time, the internet was kind of just newly at our fingertips. I felt like I wasn't getting the information that I wanted from my parents or even from my pediatrician. He was a male, I was a female. I think there were just it was a little awkward. It was a little uncomfortable. So I started doing a ton of research myself, and then kind of disseminating what I learned to my friends. So I kind of became the go-to person of, is this normal, or how does this work, or whatever. And they would know that I could go out, research it, and then come back to them with some information about their body and their health and what we should be doing as young women right then, right? Because it's a very important time to understand what's going on in your health. And I loved it. I loved every minute of it. I had a lot of very intimate and amazing experiences with friends that all kind of painted the picture of me becoming this women's health advocate of some sort. And then through a counselor, he pointed me in the direction of maybe going pre-med and thinking about medical school in the future. And that kind of started it, and gave me some ideas of how I wanted to do medicine in the future, but I still wasn't really sure what that was going to look like on the other end.
Yeah, but I can already hear it in your language with the advocate, right?
Mm-hmm.
The advocacy, because we say that all the time in the office, is that we want to help our patients become their own, greatest advocate for their health and well-being. And it sounds like that's exactly how you got into it. It's like you were just sharing resources and information, because, I mentioned this the other day, and, our philosophy is that no doctor heals anyone.
No, yeah, exactly. I love that.
And it's like, that's what we have, the power that made the body heals the body. Like, your body does the healing. We are only being the resource, the facilitator to give it the best, material that it needs to be healthy. And information is so important.
Information is power, and knowledge is power, and I just want to give people more power.
Yeah. So it sounds like you, that drove you into medicine, and then, so you did decide then, going through undergrad, did you make the decision before undergrad, or like, were you in undergrad that you made the decision?
Pretty much by undergrad, I had committed. I was doing all the pre-med stuff. I was kind of lining things up, like I was going to medical school, and I really never looked back. There was a brief time. So right after I went to Pitt for undergrad, Hail Pitt.
We're going to have a problem here.
Sorry. Hail Pitt. I did my neuroscience degree because it blew my mind that just a few ions going across a membrane creates our entire reality. So that was a really cool way to learn about the body, especially mostly rat brains, but still. The brain-body connection, right, and how important that is and how key that is to everything. And so I spent 1 year as a gap year in between college, where I would then apply to med schools, take the MCAT, all that good stuff. I just wanted to do that separate from college.
Okay.
And I worked as a nursing assistant during that time at AGH. And so I worked very closely with the nursing staff. I flirted a little bit with thinking about going to an RN and then doing an NP or something like that after. But I had already gotten my bachelor's, didn't want to go back for more school, to kind of redo some of that learning that I'd already done. Yeah. And honestly, the nurses that I worked with on 7A at AGH were all rallied behind me and said, nope, do it. Go to med school. It's what you want to do. You're going to be good at it. And so they really supported me. And then so I applied and went and got in, and here we are.
There we are. Yeah. So then let's go into, so now you're in med school. When is it that you decided family care, direct primary care? What was there a specific event or, again, series, something that led up to, no, I want to be a primary care physician?
So kind of based on the experiences helping women specifically, just because that was my group of friends in school, learn about their health, I really did think I was going to go OBGYN. So that was really kind of my mindset in med school. I told everybody in the first 2 years, that's what I was doing, end of story. My first rotation of third year of med school was OB, which I did on purpose because I wanted to kind of test it out and actually do it. Do I like this? Do I not? Unfortunately, I realized that I didn't want to be a surgeon. I did not want to be someone who delivered babies all the time. I wanted to be a primary care physician for women. And I saw OBGYN as a path to doing that. But the rest of it takes up most of your time, especially during training and things like that. And I just didn't have the mindset for it. It just was not for me. Yeah. It is for someone else with a completely different skill set. Yeah. And so I realized what I really wanted to do was primary care. And then my next rotation was family medicine, and I was at home.
You were at home.
These were my people. These were my patients. These were the conversations I wanted to have over and over again. I loved actually taking care of men as well. Like once that door was opened up, I loved it. I realized how undercared for they are sometimes because people just expect toughness and they need softness. And then children and kids and all of that just was a bright shine in my day. So the variedness of being able to, help a young mother, help an older person, and their family who's taking care of them, like all of that ability was just perfect for me.
So I think, I'm hearing that, different skill sets, right? And I think that a lot of people don't realize that, medicine has become so specialized and segmented. And so again, the skill set that you have for a neurosurgeon, is not going to be the same as, family physician.
Right.
And so what was it, I already think I know what the answer is going to be, but like, what was it, the differences in the skill sets between the OB and you're like, no, that's not for me versus family care?
Yeah. I think a lot of it was, I like to talk. So I need a lot of time and I need my patients awake. Yeah, you know what? I never say anything. I love to talk. So my patients need to be awake and they needed to not be having an emergency happen so we can be chatting. For my own personality, I'm not great in an emergency. I learned that pretty quickly. I get very stressed. I get very frozen. I just don't like the personality traits that get brought out in me in those kinds of situations. So I was like, those should be left to cooler heads. And I needed to be able to plan my day a little bit and be prepared for my visits, come into my patients with some ideas and something to work with them about. And so if I wasn't able to kind of know what was happening during my day, I didn't like that.
Yeah. So with that then, when did you start realizing, and we're gonna get to the fact that you're more of like a concierge or direct pay, direct care model, and we're gonna get to that whole system, but when did you start to recognize that the current system of healthcare was not going to be ideal for the way that you wanted to practice so you could best serve your patients?
My first inkling was when I was interviewing for residencies. So I had already decided family medicine. I loved every rotation in med school but surgery. And so I wanted to do all of the things. And so family medicine, you can do all of the things. And so when I was interviewing at a certain residency program, the program director said to me, once I told him my view of family medicine and how I wanted to be a family doctor for a community and have my own clinic and take care of entire families for their entire lives and really this high touch, very in tune type of medicine.
Intimate almost.
Yeah, right. I want to be a member of the family. I want to be the doc in the pocket that they can call when they have a question. I want them to trust me. I want them to know me. I want to know them. Mm-hmm. And a certain program director sat across from me smiling and said, that is a Rockwellian view of family medicine. And I decided to torch the interview right there. And I said, you said that like it's a bad thing. I think that's a good thing. And
challenge accepted.
Yeah. And then I kind of sat back for the rest of the interview knowing that wasn't going to maybe go so good. I wasn't going to rank them highly. They weren't going to rank me highly. It was fine. And so, yeah, that was kind of the moment when he said to my face that you can't do
practice. That. You can't do that.
You can't do that. That doesn't exist.
Tell a strong woman that she can't do something and see what happens.
Ooh, I stuck my heels in. Yeah, no, exactly. I did that in high school too, actually. That had me headed towards the medical school path too. So don't tell me I can't do something, then I will do it. But yeah, so that was one of the moments where I was like, why? Like, why is it Rockwellian? Why is that outdated or too old fashioned? But I didn't really understand until I started working in residency and actually doing the work behind the scenes and realizing what was really going on.
Okay. So what was really going on? What was it? Yeah, I know. Right? What was it about the system that you were like, no, this isn't the way I want to practice?
I kept being guided to be more efficient, right? We only have so many hours in a day. I need to see 14 patients, throughout the day efficiently. My MAs should leave on time. And so I kept getting pulled into offices by the office managers or other physicians who were genuinely trying to help me by trying to guide me to be quicker, spend a little less time with patients, don't cover all the issues on the list that they brought in, because in reality, with the structure that we had, we didn't have time to do justice to all those things, right? So if Jane thought that I went down her list and thought really well about all those things and we were moving on, she might not bring those things back up. And so instead, by making the list shorter and manageable, we could actually do a good job. But again, it wasn't me. It wasn't a me problem. It wasn't the patients that were the problem. It was the schedule was really packed. I couldn't have free slots, like appointment times open during my day to accommodate my patients who needed to be seen more urgently because of money concerns and things like that. And so just how to survive in the system, it wasn't jiving with what I thought needed to happen for those patients to actually get better.
Yeah. So, kicking the can down the road, right? To come in,
Or deciding all the referrals.
Yes, get the top priorities, taken care of, and get them out of the office so you can get to the next person.
So I can get to the next person and then bring that person back in, right? Which means another copay for them, another trip to the doctor's office. They work, they have family, they have dogs. I mean, that's not an easy thing for people to do, knowing that their appointment time is when it is, and it was, if they were seeing me, it was probably going to start later because I was spending more time with patients earlier in the day, and that snowball effect, which was not nice to my patients, but I felt like I needed to do in order to give everybody the care that they deserved.
And so you think the system was set up like this?
No. I think initially, when everyone says, oh, back in the day, my town doctor, they had it set up much better. As health systems and insurance, vertical integration, all that stuff started to take over, everything started to shift. These big systems bought up these tiny offices, and then things started to change. They couldn't have mornings open for sick visits for kids before school because that's money that they're losing by not churning out patients during that time. So I think it was kind of that takeover, and that changed everything and shifted all of the ideals. Okay. And then people started using insurance for everything. Yes. And so then once they started using insurance for everything, insurance started making the rules.
Yes, there it is.
And then when insurance started making the rules, everybody started losing. Except for the insurance companies.
Yes.
So the patients and the doctors could no longer do medicine the way that they were used to. And I think that was the big change. So I think we talked a little bit about how doctors actually get paid. And so
and we can chat about it. So how, because again, we don't do we do direct pay at our office.
Yes.
And I started from the beginning. I'm now 14 years in practice, and from the beginning we went non-participating with all insurances. If someone came in and had good out of network, insurance coverage, we would try and bill it for them and, incorporate that into their care plan, but it was never 100%. So the patient was always paying something towards their care. And, the more and more I looked at it, it was like, I can just eliminate this headache and just make it a very fair fee and, allow people to be very happy and not worry about it at all. And and what that does for a practitioners, and again, I'm gonna get to this because it might sound a little selfish, when you first hear it, but it's like when you take the practitioner out of that system, the amount of stress reduction that just is alleviated, and now we can put our full focus and attention on our patient care, on our clinical care. It's incredible what the healing that happens, right? Exactly. Because
in us.
Because we're not waiting 3 months. So again, talking about, how does a physician get paid? I always say, if I went in network with insurance companies, I would not have made it out of my first year of business because it's 3 to 6 months to get paid on a visit that you did. So it's like, if you're, I was literally at the end of I opened my office on a $50K line of credit. It wasn't my line of credit. It was a very close family member who helped out. And I was at the end of a $50K line of credit of theirs. And it was like, if I didn't start seeing patients and get paid, I wouldn't have made it out of my first month in practice. And so, again, I'm always so grateful. I still have 1 or 2 patients that came to see us within the first couple of months that still come in. And it's just like thinking of what they did and, kind of prepaid for a little bit of care, for those first couple of months. It was like, it made a massive difference for us to be able to pay our rent and make it to the second month. Yes. And, again, so 14 years later, had I been in the insurance model, never would have made it outside that first couple months of care.
It's impossible.
Yeah. So when we talk about like what it does to the, practitioner, like it really does make a difference in terms of the level of care that you're receiving, because we're not constantly thinking about, when's our next paycheck coming from. There's a level of service that is there, and just we expect to give because we know the relationship is between us and our patients, not some third party that we have to go hunt down to get paid the value that we provided. So where was we going with that?
Background. No, that was perfect, because that's exactly it. Like it's healing, and this is where it started to break me. It was figuring out like, how does this actually work, right? Like I want to be a doctor, I want to do these good things. Okay, fine. I got to family medicine. I'm in an amazing residency program. I'm at my dream spot, and then the real learning begins, right? And I think I'm going to be learning the medicine side of things, and I am. They're definitely teaching that. It's a crash course. You're learning it all at once.
Very quickly.
But there's also a whole slew of things on the back end about how to bill, how to code, and then how to get paid. And honestly, even in residency, I didn't get the full picture. So I'll explain. So in residency, they start teaching you how to bill and how to code in order to get paid. Reimbursed is the word, from insurance companies. So a common thing that people will notice is if they go in for their preventative annual exam, which should be an exam without a copay typically from an insurance company. That visit has a whole list of things the doctor should be doing that we know what it is, that needs to get done during that visit for it to be free. If the patient has a problem or a question or something that's kind of outside of that predetermined list of things, typical predetermined
by the insurance company.
By the insurance company, exactly. List of things we're allowed to talk about. Then we would need to bill a problem visit kind of on top of it. So you were in the office for one visit, you saw your doctor for 7 to 15 minutes if you were lucky. And now you're getting a copay that you didn't think you were supposed to pay, and maybe even bills on the back end for other things. And granted, that bill might not come for 3 to 6 months, so you might not even know it's happening because it might take a little bit, but that's what that bill is for. And it's because we have to do that to survive. If we don't, insurance reimbursements are so low on the usual care that we provide, we just wouldn't generate enough to pay our nursing assistants, our medical assistants, or nurses, all of the staff that we need, and ourselves. Our admin, the billers and the coders, right? Because there are people on the back end reading the notes and kind of rebilling, recoding, and trying to get more.
Trying to optimize, the
and that just makes the overhead very big. So the funnel above your doctor in a typical system is very, very large, full of administrators and all these other people, and then funneling down to the doctor who's just trying to keep it all together. And the individual doctor, they want to do the best for you. It's not their fault. The system is just built to not give them the time, and to not give them the place to do the right thing, I think, most of the time. But they do a good job. They do a really good job being there. So then I learned when I started looking at private practices, right? So I was like, okay, what am I going to do with my life after this? I was a little demystified about getting an employed job. I just was seeing what was happening already as just a resident, and I could only imagine what would happen if I was employed by these systems directly. So I started looking at private practices and talking to them and shadowing with them, working with them, thinking about buying in or taking it over myself in the near future. And that is when I learned about 40 to 60% of what doctors make is not from the reimbursement side directly. It's from these metric bonuses that come through these integrated networks. It's just a bunch of mumbo jumbo. But basically, there's a secret list of things that you need to be doing as a doctor or need to have on your panel that insurance companies have. So it's different for all the insurance companies. And they kind of look at your panel. They say, were your blood pressures in range? Were your A1Cs good? Did they get their colonoscopies? Did they get their eye exams for diabetes? Whatever things they care about that year. And if you hit a certain percentage, then yay, you'll get the bonus. Or I wish it was that simple, but it's not. But if you and your entire network hit the indications, then you get this bonus. And you rely on these bonuses, right? 40 to 60% of your income, you can't just say goodbye to it. Yeah. And so that metrics basically creates a secret list in the back of our head, or it's right on our electronic health record, of things we kind of need the patient to do for us to survive.
Yeah.
And so that's confusing and that's difficult as a doctor, right? My job is to give you all the information to have you make an informed decision. But if at the end of the day, your informed decision is you do not want to, or, you don't think it's necessary, or you just, you don't agree, then somehow my livelihood is threatened by that.
Wow.
Even though I've given you all the information to make that informed decision, I've done my job, and you're an adult person who's allowed to make a decision.
We live in a free country that you can make a decision about your body and autonomy.
You should. And so when you feel like you're getting kind of pushed, like you are, and maybe we really do believe in colonoscopies, right? We're big fans across the board, I think, for the most part. And we believe in it and we want you to get it, but the outcome of whether or not you do it shouldn't determine whether or not I can continue to be a doctor. It should be if I'm doing a good job giving you an informed decision. So right by you explaining all of that, to me, it's like the insurance company is pitting patient and doctor against one another. Exactly.
Because if you, if your income is tied to that, talk about a conflict of interest, right?
Right? Yeah. And not one we signed up for.
Right.
We don't want.
Yeah.
We didn't sign up for this.
Yes. Yeah. You do whatever you do.
Well, yeah.
And so that's a whole other game, right? Signing, going in network contracting with an insurance company. The doctor is required to sign a contract, right? And probably, it's probably longer than the bills in Congress, right? It's just like, but you're literally, required to do all these things. And if you don't, now you're losing, you're losing money. And if you're in a multi-doctor practice, which the majority are in, tied to these large practices or hospitals, well, now the practice is losing money. And so, now your partners are mad at you because you're like, well, we're not, you don't have time to do all of this. And so, so now you get frustrated with the patients. The patients are getting frustrated with you because you're pushing services that, again, people are very well researched. I always say, Dr. Google is a thing, and it's okay. Like, there's a lot of good information out there. You have to be able to sift through what is good and what is crap. But, there are a lot of very informed patients when they come into, the office. And so for the days of the God complex for in medicine and just healthcare in general, it's like they're gone. It's like, so they should be, right?
It should. But someone is making it a thing again.
Yeah.
We worked really hard to get out of that system, and now all of a sudden it's being brought back on us where we have to tell people what to do and really kind of hope they do it. And that is not what I came here to do,
So share, please, if you will, please share the story of when, it just hit you that there is no way that you can practice like this anymore. You talked about, I think you know what I'm talking about, right? It was that moment that, because you were telling me in the office whenever I came to see you that it was, they were doing their best in medical school to beat the caring out of you. I think was almost to beat the caring out of you, because that's, if you don't do that in the system, then you can't survive, financially, and then you can't continue to serve people. Not that it's the ideal environment that we just talked about, but there was a story that you told me that it was the moment that you're like, I can't do this.
Yeah. So don't judge me after this, but it happens, and it's a hard system. So residency is long and arduous and difficult, and you work a lot because you just need to learn as much as you can as quick as you can. And I was heading towards the end of it would have been kind of middle of the way through my third year. So last year for family medicine, it's a 3-year program. And so I had gone through all the hospital training and all this stuff, and then I'm in the office, and I'm seeing patients, and I'm running behind, and I'm stressed out, and I don't even know, just getting berated, it feels like, from every angle. The in-basket is full, and I'm getting, reprimanded about whether or not I'm going through my in-basket efficiently enough while I'm also running clinic. And then I had a patient coming in to see me. He was having increased pain, and he had pretty significant cancer. And And his pain had been hard to manage up until this point, and it's a difficult situation, and emotionally it's very hard, right? Because if his pain is getting worse, that means his disease process is getting worse, and so that feels like a lot. And I found myself just typing on my computer and really monotone saying, if it's not a 10 out of 10, I don't care. And I had a med student with me, and I felt her like bristle. And then I like had an out of body experience where I replayed the whole moment in my head and saw it and was like, what just happened? And I'm getting chills now thinking about it again, of just like, wait, what? And it was because we had this laundry list of things to do for him already. That was from that discharge follow-up and all this stuff. And there was all these things that needed to go on. And I like couldn't fathom doing one more thing in that visit. And especially something so complicated as managing pain. And I like scooted back on my little stool and was like, I am so sorry. That was out of line, unprofessional. And I was like, I need to go take a minute. And I just stepped out of the room. I like talked to my med student, was like, that was never okay. Never do that. That was bad. And then I went immediately to the people above me and was like, I need help. I am burnout. I don't care anymore, as seen by that statement. And I'm going to do someone harm. If I don't get some help. And then luckily my residency program was extremely supportive. They swooped in, took great care of me, did what they needed to do to get me better. I went to therapy. I'm still there. And things are much better now. But that was just a moment that I never saw myself doing. I'm an extremely caring person, extremely compassionate, almost too much sometimes, empathic, all that stuff. And I've always known that about myself to my core. But in that moment, yeah, that was just terrifying of how much like the system succeeded. They got me where they wanted, they broke me down to nothing, and then they could build me back up now as anybody that they wanted me to be. And I'm very lucky that my program stepped in and didn't let that happen when I called for help. But it was just a sign that the system had worked in that moment where they had gotten me down to the base of nothing.
So, and that's, so you said it, like you recognized it. But how many of your colleagues, they go through that experience, but then they just keep going forward because that's the solution, right?
Yeah.
And that's literally the intended path of the system is they want to break you down and almost be a cyborg of the system, so that it's like you're just churning through patients and churning through and
they don't care. If we had to leave, physician suicide is a very significant problem. If unfortunately we leave it, they just hire someone new, right? They don't care. So.
Well, let's pause here because that was, and again, thank you for sharing.
Yeah,
that's so important because it's such a pinnacle of what is leading you into what is now going to be the solution to the broken system. So we're going to pause for a minute. We will be right back. Thank you.
You've been listening to another episode of What the Health? The podcast where anything health is fair game with your hosts, Dr. Dan, Angela, and Dr. Riley. Brought to you by Churro Family Chiropractic. If you'd like to learn more about some of the resources mentioned on this show, or you have questions about something that was discussed, please reach out through our website at www.turofamilychiropractic.com. Remember to like and subscribe to What the Health Podcast to catch all the latest episodes and replay your favorites. Thank you for listening, and remember, we're always here to help when you find yourself saying, what the hell?